So you get this guy's ECG. This is not one of your ECGs, but you know he's got a dissection, but you get his ECG. And you can see in that ECG that he's got some, maybe a little bit of hypertrophy. You know, whenever you see the complexes of one lead overlapping the complexes of the other, he has a little bit of hypertrophy. Does that change what we give in this particular patient? You want to give Libido, right? Libido is the drug of choice for most of these. Your hospital doesn't have any. You've been so prolific in your use of Libido that they've run out of Libido in your hospital. So what else can we use? What can we use? GTN infusion, it's a venodilator, it's an arterial dilator, it dilates all the vascular smooth muscle. It has an effect on coronary blood flow and left ventricular diastolic volume. We have to be a little bit careful of, because it can cause a left ventricular outflow tract obstruction due to it can sometimes cause a Venturi type effect. And the other thing that it can cause is a reflex tachycardia, which you don't want in a dissection. What about Nitroprusside? It's very similar. Cyanide toxicity and renal impairment, sure. Again, a reflex tachycardia is the problem. And if we're going to use this, we're going to have to add some other kind of beta blocker. Esmolol is probably the safest, shortest acting beta blocker that we have that we can use.